Hello everyone, thank you so much for your patience. We had a technical issue this side, but it's all been completely fixed now. And we're recording, and we'll put this to video and let you know about that later. But I suppose as you've been waiting, let's cut straight to the chase. And we are really delighted to welcome Professor Robert Winston today, who's going to talk about not chest pain, but infertility. And you should all be able to see your screens. And if I can hand over to you, Professor Winston.
Yeah, thank you very much indeed. I'm really sorry you've been kept waiting. I've had to switch computers for some reason. I don't quite know why, but luckily I've got two laptops. So this is my second one, which I don't normally use. Let me just explain that slide to you. I'm going to argue that one of the key problems in reproductive medicine generally, and it applies to both specialist medicine and very specialist medicine, IVF clinics, and indeed general practice, is that infertility is treated like chest pain, i.e., it is not a diagnosis. When somebody goes through with chest pain, you don't immediately order, let's say, a cardiogram, or indeed go further and just do, let's say, open heart surgery. And actually what's happening at the moment is exactly that. People come in, infertility is regarded as being a diagnosis, and they're treated with in vitro fertilization or given drugs or whatever. It's really important that we try to change that attitude. So what I can't do now, of course, is get my, oh dear me, it's just hopeless, isn't it? Right, so that's my next slide. Can you see that? Are you with me?
Yes, we can see that. That's brilliant.
So basically, very briefly, here is an example of just sort of major causes of reproductive problems: sperm dysfunction, ovarian failure of some kind, tubal disease or pelvic disease, uterine disease, systemic diseases, pregnancy loss, and of course the other thing, of course, would be psychosexual. But the causes of infertility are multi, and I've only put down a few of them here of common ones, but actually we should say that there are at least 100 reasons why infertility is an issue. And unfortunately, one of the problems is that diagnoses are not made. So I think the first thing to say is that what one should not be doing is just referring the patient to an IVF clinic. And I just want to emphasize this to you, because this is where general practitioners can always be really helpful. It's just forgotten what a devastatingly debilitating problem infertility is. It starts off with just anxiety. People don't really believe there's anything wrong. Then they start to realize that they're not getting pregnant, or pregnancy is not happening. There's a loss of self-esteem. There's a feeling of guilt. There often is poor communication. It's very, very common, much more common than people realize, for husband and wife to have, or partners to have, a real problem with communication. And often both partners feel isolated, particularly women. And then, of course, you get recrimination. And it is extremely common for there to be sexual dysfunction, not because it's clinically a problem, but it becomes a problem as a result of the symptoms they're getting. So impotence is common, and actually so is depression. And I therefore think it's much underrated how much a general practitioner can really be of benefit, locum or full-time. I think this is something where some sympathy and understanding that there are ways of getting around this, that actually most cases of infertility are certainly treatable, and usually not with in vitro fertilization. In fact, in vitro fertilization has, as I'll show you, a very high failure rate. So the incidence of infertility is common. Don't let's go into this in great details. Nobody's got a very good idea of the UK, but we're guessing that it's about, let's say, 1 in 10 couples. It may be more. In fact, according to some authorities, it is more. I think that's an overestimate, but 1 in 10 is probably right. One thing, of course, one can do with infertility is at least to understand the sperm count, because, of course, about 1/3 of the time it'll be a male problem, 1/3 of the time it'll be a female problem, and the rest of the time it'll be a combined problem. And actually, of course, that means that 2/3 of the time the sperm will be somewhat involved in the problem, and 2/3 of the time, actually, it turns out, there will be both couples involved anyway. So just to remind you of the WHO figures, which you can look up, and I was to say straight away that these are very unreliable, because, of course, actually, although a man may, let's say, ejaculate nearly 10 million or 100 million sperm, as you see in this WHO estimate, a lower point being 40 million in entire ejaculate. Actually, many ejaculates have far fewer, and indeed you need one sperm actually in the right place to get a pregnancy. And surprisingly, people with very low sperm counts can do this. It depends very much on a whole range of other things, particularly the quality of the sperm. And the quality of the gametes, both egg and sperm, are extremely important and underrated. And unfortunately, there's not nearly enough research going on to understand that. So motility is one of the best ways of looking at this. And there are various tests that should be done, which do not involve a sperm count, but have to be done by professional clinics or hospital units, which involve, for example, immersing the sperm after ejaculation in various fluids to see how they move, and also looking at the morphology in more detail than you can do under a general light microscope. So with the issue, of course, is that this is really an important graph. In fact, in some ways, this may seem ridiculous, but it's probably the most important graph I can show you. It turns out, of course, that the more often you have sex, the more chance there is of getting pregnant. And if you only have sex once a month, your chances of getting pregnant in that month are really low. And the interval, of course, is shortened the more often you have sex. And I think it's really important to try to persuade people to live a normal life. Don't blame it on stress. It doesn't really help them. In fact, there was one very famous endocrinologist in San Diego who I remember at the age of 95 gave a lecture, which I sat through open mouth listening to him. It was brilliant. And he said, you all think that stress causes infertility. In fact, in my view, there's quite a lot of evidence to show it improves fertility. So I think we need to recognize that different people will have different responses to stress in different sorts of way. And therefore, we must remember that if you don't offer your chance of getting pregnant, and so frequently intercourse is happening at a very, very low rate. And just very briefly, as a very rule of thumb, if we're going to start investigating, I think it's reasonable to investigate anybody who's had at least a year's infertility. And I think if they're over 30, probably a bit sooner. And there are various things that one can do in addition to just reassuring people. But I think you can see some of the things on this chart. Actually, I can't see the chart properly because this screen is not working as it should do, because it's my backup computer. But essentially, look at doing temperature charting is reasonable for a short time. I think hormone tests on their own aren't much use. We'll come to some of those in a second. But more and more, I think it's recognized that poor ovarian reserve is an important issue. And here you see it here. So, for example, here's a woman of 26 on the left of your picture, and you can see in that tiny piece of ovary that we've biopsied, we've got something like 19 or 20 follicles, and this woman of 38 has only got 4 follicles. This decrease in follicles is common. It's much overrated, but it gives you an indication. Of course, these follicles all contain eggs, but the older we get, the less competent, for various reasons, molecular reasons, will eggs be capable of producing a pregnancy. You can see here that in a very, very big study, and various studies have been done since this, you can see that actually the real decline in eggs doesn't often come much before 40. In fact, usually quite a long time afterwards. So many of these reproductive clinics that are telling people they must get pregnant straight away are not really helping. They, in fact, make it worse, I think, because they end up going to infertility. And I have to point out in vitro fertilization. Once you start in vitro fertilization, you actually make the patient infertile because, of course, they're not having intercourse either before the treatment or immediately afterwards or during the actual treatment month. And I think that is not a good, not good advice. So hurrying into IVF, high-tech medicine, is not nearly as useful as just doing fairly simple tests. We'll be looking at some of those. Now, one of the things that obviously you'll must be aware of is the much dreaded AMH. Every single clinic is now throwing the AMH test at people who are trying to get pregnant, the anti-Müllerian hormone. Essentially, this is a hormone which, roughly speaking, is secreted by the cells which surround the eggs, the granulosa cells. So the more eggs you have, the higher the hormone will tend to be. And it has a key role, really, in the female fetus, but not really during actual reproductive medicine. So it's only a rough measure of the number of eggs in the ovaries. And obviously, the higher, the more eggs, but it's only a snapshot in time, and it varies very much. So even though when women come to you saying, the clinic says, my AMH is low, I've got to go for IVF, where do you send me? You've got to be aware that actually one of the things that the AMH does not do, and nobody ever says this in the clinics, is that it doesn't actually predict fertility, and it doesn't predict the response to treatment, or indeed when somebody may start the menopause. Indeed, it's quite usual for people who are perfectly normal to have quite low levels. So a level of 1 to 3 is completely average. And unfortunately, what clinics don't do when they tell patients this is that, in fact, there is a very wide variability. And unfortunately, as you may know, very many private clinics now are offering what's called an MOT test. And the AMH is a big part of this. When people come in because they want to freeze their eggs, they do an AMH test, they find it low, and they immediately submit them to egg freezing. I won't show you the national figures for the UK, but by pressurizing the Department of Health, I can tell you the chance of a single frozen egg producing a live birth is about 0.2% after treatment with IVF. So egg freezing is not a great option. Embryo freezing is, but you've got to have an embryo. So I just want to mention that point in passing. So you can see here, the key issue is that people get very, very worried about this hormone now, because every woman now who's in her late 30s, if she's professional, is starting to think she may be leaving it too late, and she goes for this test. It's something just to be aware of, that it's limited. Meanwhile, what we've forgotten is a much more common, a much cheaper test, which is the follicle stimulating hormone. And of course, it's true that the FSH rises very much as you get towards the menopause. But in most women, the FSH is not risen unless they're seriously infertile. So it's actually quite a good test to consider. It's a simple blood test, just like the AMH, done at the beginning of the menstrual cycle. And any level below, let's say 10, would be a very reasonable, give somebody a very reasonable chance. Above 15, I think one has to say that there will be a serious problem. Possibly the woman is premenopausal. And you can see here from these data taken years ago when I was, doing fertility, don't know when, 40 years ago, maybe more, 45, that on the whole, infertility follows the menopause. The menopause, is about 10 years after this fertility. So most women who are going to be menopausal, let's say at 52, will start to be infertile at 42, which is about the national average. The other issue is to point out that there's quite a lot of evidence that when you do get pregnant in those very old age, the aneuploidy rate rises. But actually, that doesn't mean to say you're going to have an abnormal pregnancy. It just means you probably won't get pregnant at all. Now, one key issue, and this is very relevant to in vitro fertilization, is that it requires stimulation with follicle stimulating hormone. And you can see this work we did in mice, now something like, I think 35 years ago, you can see that as you give more and more FSH, which of course we do routinely in IVF, you get more and more abnormal eggs. Now, what you see in the mouse is something far worse in the human. Humans have very high aneuploidy rates with high doses of FSH. So one of the problems is that the current stimulator regimes that we all use, using these hormones, are somewhat likely to cause the very problem you don't want to have, which is having more abnormal eggs. We'll come back to that in a second. Here's a typical aneuploidy cell taken from a study Kate Hardy and I did some 40 years ago. You can see there are 4 white blobs here, which represents chromosome 1. And you can see 3 blue blobs here, which is chromosome X, and 1 red one, which is chromosome Y. So effectively, this is a classic example of aneuploidy caused as a result of stimulating with FSH hormones. You can see this all the time with all sorts of chromosomes. Here's a very good example where chromosome 13, 16, 18, 21, and 22 are all abnormal in a person who subsequently had a perfectly normal pregnancy. without any stimulation. So one has to be aware that stimulation may not be such a good idea after all, but normal treatment with unstimulated cycles using in vitro fertilization is not very successful either. It is in a few people's hands. And occasionally, of course, you get translocations like this, particularly where women are having miscarriages. I have to say that one of the key issues, which is really important for where we can really rely on a good general practitioner, is for them to understand that miscarriage is, first of all, extremely common. Something like 1 in 3, 1 in 4 pregnancies miscarry, but also they will be associated quite often with chromosomal defects. So if somebody is miscarrying, it's hugely helpful if immediate referral to get them in to have the any fetal products looked at microscopically. This is not being done enough, but in fact the chromosomal tests on the products of pregnancy are really important. You can see there are all sorts of things here. And this woman, who's got 3 cells, cell 1, cell 2, cell 3, all from the same embryo. They all show a different pattern. So chromosome 2 in cell 1 is quite different from chromosome 7, but there's a bit missing in chromosome 7 on the top, as you can see. In cell 2, there's a translocation with chromosome 7 and chromosome 2, and in cell 3, there's another translocation as well. So I think the point I'm trying to emphasize is that these do require very careful analysis, and that really does mean getting fresh products if we possibly can. As people get older, their own eggs are not nearly as successful pregnancy as donor eggs, but the difference is not quite as striking as is often claimed. And in my view, one of the key things is to try to persuade women who are in their late 30s and early 40s that actually just trying to get pregnant naturally more often is generally more successful than doing in vitro fertilization with stimulation. And even when the FSH is high, and particularly in some cases when the FSH is high and the anti-Müllerian hormone is low, the chances of getting pregnant are worse with treatment than actually undergoing natural cycles, just simply having just regular happy intercourse, trying to make this a pleasurable event rather than an anxious event, as it often does do. Waiting for the next menstrual period is one of the most unpleasant and difficult issues that infertile couples have to face. Now, let me come to some of the things which are ignored and need to be considered. First of all, far too many women go into in vitro fertilization without proper investigation, particularly of the uterus. So this is a hysterosalpingogram, which would have cost probably less than £100 to the NHS. And you can see that the edge of this uterus is extremely irregular all the way around. This patient was complaining for a long time of menstrual pain. She went to an IVF clinic and they didn't do very much. They gave her 2 cycles. She didn't like them very much, so she went to another clinic. She had a total of 4 treatment cycles with in vitro fertilization, with embryos being put into this uterus, which had no chance of implanting because nobody did a hysterosalpingogram. So she ended up paying thousands of pounds for treatment which couldn't have probably worked. That needs to be diagnosed. And I think one of the real issues is that anybody who starts to have any kind of pain, if they're reasonably fit in the pelvis, one needs to try and find out what's wrong and try to make sure that they do get gynecological help, as well as just merely going to a fertility clinic. So here's a good example of where a hysterosalpingogram gave us a clue. She was treated with hormones to try and reduce the adenomyosis, but it never actually worked. Now, this woman was treated with in vitro fertilization numerous times, and unsurprisingly ended up with an ectopic pregnancy. You can see how the tubes on the other side, I don't know if I can use a pointer, might be able to. Does that enlarge or show you anything? You can see the tubes are ending in very, very irregular lines. So here again, the hysterosalpingogram doesn't really show the tubes are blocked, but the lining is all irregular. And that indicates really that she's at risk to an ectopic pregnancy. And I think one has to say that there may be a case here for removing the tubes. On the whole, I think that one has to recognize that probably straight in vitro fertilization is the best thing to do. I would certainly advise that without removing the tubes, and just being aware that an ectopic pregnancy may be a bit more likely, but not nearly as likely as people would think. This patient, if I'm right, let me just come to, I can't see the bottom of the slide, but I think there's a delta. There should be a delta at the bottom there. Can you see that? I don't know if you can see that, the delta. She was from Greece. And if you look at this uterus, it is T-shaped. In fact, there's no uterine cavity. This is the uterine cavity. It's basically just the cervical canal and two horns, which are completely separated. So this woman had a mother who had difficulty getting pregnant, but nobody asked her about her mother. And basically, her mother had repeated miscarriages in Greece, and finally, she was given progesterone treatment during early pregnancy. And of course, when she got a female fetus, it got masculinized. And this is the response. So she, the patient, had really had this defect since before birth. This causes two problems, really. Sometimes menstrual periods become rather lighter than normal, but more often they're nearly always infertile, and occasionally are lucky if they even get a miscarriage. Most of the time, they have total reproductive failure, either with an ectopic pregnancy or a miscarriage or nothing at all. This patient never got pregnant, and nobody got her family history, which was pretty simple. And the net result was that 5 treatment cycles with in vitro fertilization in one of the most famous clinics in the world, I won't say which one, resulted in, again, this woman then finally having a diagnosis when she came for a hysterosalpingogram. Now, I think that's a complete failure of medicine. I think it's probably, it ought to be negligent, but there you are. Unfortunately, the market is attractive both to clinics and to patients. And I have to say that one of the problems about in vitro fertilization, that as far as the clinic is concerned, if a patient fails to get pregnant, it increases their income because the patient will come back again. And I think that's one of the big issues with private medicine at the moment in reproductive medicine. It happens elsewhere in medicine, but I think it's often worth bearing in mind that patients tend to go because they think that's the best thing to do, the attractive clinic, which has on paper the best results and is generally often more expensive. I don't think the evidence that they're any better by charging more money is really there. And I think one has to be much more aware of not the advertising, but actually the care. This patient had an irregular horn of the uterus, you can see on the left side there, with a fibroid in the uterine cavity, and that was preventing implantation. It was removed surgically, and she got pregnant without further in vitro fertilization. And this patient is somebody who came from a Middle Eastern country, and you can see that she's got this little defect in the horn. You see that little dark area in this point here. So that area is very, very characteristic of one disease. Notice both tubes are also blocked. Now, they noticed the tubes were blocked, but they didn't notice this. This was very good evidence of tuberculosis. And tuberculosis of the uterus is really a very serious disease, even if it never causes any further problem systemically, because actually these people will always be seriously subfertile. And if you look at the literature, the chances of getting a pregnancy, even without anti-tuberculous treatment, though that's been tried, is poor. This woman did go through TB treatment, but didn't become pregnant. And I think, given the fact that she came from a country where tuberculosis was common, I think it's surprising that that wasn't fairly well recognized. I have to say that tuberculosis is somewhat on the increase in Britain now, partly because of our immigrant population, and partly because, in fact, tuberculosis has never really been completely killed off. This is an extraordinary story. You can see that after a hysterosalpingogram, following in vitro fertilization, again, 4 failed treatment cycles, and this patient spent almost £20,000 on those treatment cycles. She had this hysterosalpingogram done, this X-ray. 2 uterine cavities are shown. It's a double uterus, a pretty common congenital abnormality, and surgery to remove that central septum here Let's just get it into line there, and joining up the uterus from below. So it only needed a vaginal treatment resection. It didn't need an abdominal operation. This patient got pregnant after 3 months after the surgery. And one has to feel quite angry about that, I think. One has to feel very sad for the patient. But I think the fact that that is missed and not taken very seriously is really rather shocking. Occasionally, when you can't get a decent diagnosis, sometimes MRI may be helpful. MRI is being used more and more, and you can see here the walls of the uterus here are irregular. The hysterosalpingogram wasn't very clear, but this irregularity is a good example of adenomyosis, quite common in women who have constantly bad periods, often with irregular flow, but also associated with menstrual pain. MRI is expensive, but I think occasionally if you have intractable pain in the pelvis, it is well worth looking. And finally, of course, most important is secondary infertility. Secondary infertility is very common. Somebody gets pregnant, they have a baby, maybe they had a bit of a fever after the pregnancy, sometimes they've had a forceps delivery, it's been slightly complicated, sometimes a cesarean section, but actually the real problem is that the uterus is damaged, probably as a result of infection. They have adhesions. Adhesions in the uterus are extremely common. And this is another patient who had multiple IVF treatment cycles. And eventually, of course, she had a hysterosalpingogram. And it was only when the hysterosalpingogram was done, you can see that these adhesions were cleared. I could show you the follow-up X-ray, which shows that her uterine cavity was normal. And then, of course, she has a chance of getting pregnant. And of course, that is something to be recognized, that actually secondary infertility nearly always means, or very often means, that there's something else going on that we need to be looking at, proper investigation, which I think may well include looking at the uterine cavity like this, but also I think to some extent using laparoscopy. So laparoscopy is not sufficiently done in my view. It started to get lost, and unfortunately the National Institute now still doesn't really recognize it as being essential under the health service. I think it actually ends up wasting more money than saving. But here's a woman whose fibroid wasn't noticed at the back of the uterus, and the lower half you can see is actually quite expanded. It wasn't obviously obvious on X-ray, and it was missed on by manual examination, and it was missed on by manual examination by a good clinician. This was not a person who was, but he then went and did a laparoscopy, and you can see that this uterus is actually irregular. So that's worth considering. Another example of secondary infertility, patient who had a normal birth, normal baby. She had a forceps delivery. She was not terribly well for a couple of days after delivery, but that was it. 5 years later, she presents with this massive adhesion in the in one side of the pelvis. Here's the uterus up here. So that's the uterus here, around here. That's the uterus, and here's the tube and ovary, just one massive coil. And of course, it's completely subclinical. She never had any serious fever. She never had any evidence of pain, or she was a bit unwell immediately after pregnancy, but she, of course, had damage to both fallopian tubes. And a laparoscopy, of course, could have said, look, there's something here, we need to do IVF straight away. Actually, in fact, IVF never worked in this patient. As often happens, they have ovarian disease, which is associated with the infection. Salpingo-oophorytis is not just salpingitis. Oophorytis is quite usual. The blood supply is the same for both organs. So it's not surprising that very often people who've had pelvic inflammatory disease will have problems with the ovary and problems with ovulation. And here is another patient who had silent PID after a delivery. And again, you can see a massive adhesion behind the uterus down at the bottom here, and a tube clearly which is swollen and dysfunctional some time after the delivery, with fibrosis and more adhesions at the bottom. Very, very important too is that so often people doing laparoscopy do not look into the upper abdomen. And this is a classical example of hepatic adhesions attached to the diaphragmatic peritoneum, the subdura. So it's underneath the chest wall. This is where you've got a collection of infected fluid. And in any woman, if you see this, it's very much likely to be due to infection, often after a pregnancy. This patient was just after infection. She hadn't been pregnant ever. But that is a key issue, that when a laparoscopy is being done, it's really important, first of all, that photographs are taken, and secondly, that the surgeon is wise enough to recognize you have to look into the upper abdomen as well as the lower abdomen. So actually, who you refer patients to is actually quite critical. It needs to be somebody who really understands what they're doing with the laparoscope. So I won't worry about these concerns too much, but certainly I think there is an issue about failing its importance, failure to make a proper diagnosis, and I think to some extent reckless use of in vitro fertilization and very poor levels of psychological support, with the wastage, of course, of NHS finances. So let's just go through my final 3 slides. I think there are 3 slides. I think with a general practitioner, the first thing to understand is that the choice of the clinic is really critical. The clinic who actually bothers to write letters and actually communicate with the general practitioner is, I think, short on the ground. I think they're really important. When they have this dialogue, you can work together with them. And I think that clinic should be certainly something which is one that the patient feels comfortable in, doesn't feel that she's being fleeced or treated rather trivially, because it becomes a bit of so often a conveyor belt. Secondly, a clinic which does assessment before IVF, doesn't just start them straight into IVF. I've set asterisks 3 areas which I think are massively needing of really looking at it. One is ovarian stimulation. I think at the moment ovarian stimulation is done very much on a commercial basis. That is to say, it's done like a factory. People are just given FSH. Hormones are not properly measured. Therefore, the response isn't fully understood. Ultrasound may be used because it's easy to do that in a clinic. The hormones are not properly looked at. But failure can occur at every stage. And so the next thing that I think is really important is the culture of the embryos. We're still culturing human embryos in fluids which are made commercially and which have a secret formula. There are 4 main culture media which are on the market at the moment, used widely in pretty well every IVF clinic. And research in my laboratory shows that the proteins vary in these fluids, that in fact the percentages of different amino acids are different in each culture medium. And I think there's a real need to understand the culture of embryos, because the biggest area of failure is embryos failing to proceed into embryo development from the time of fertilization. And lastly, of course, we still don't understand embryo transfer. The problem really, of course, is that at the moment of embryo transfer, every woman naturally sort of hallucinates. She thinks she's pregnant. She wants to believe she's pregnant. She goes away. She treats herself incredibly carefully, perhaps won't even stand on a stool to change a light bulb, whatever it might be, because for the next 14 days, they feel like an invalid. But actually, it's a very, very emotional period of time. And I think one has to understand that that emotional period of time has not been properly handled by the professionals. It needs much more recognition that people do need reassurance, but also, of course, we need to have much better understanding from clinics that it does mean that you have to follow up the patient. So a clinic that doesn't follow up people after transfer, whether they've got pregnant or not, is not doing a great job. In general, what they tend to do, if they follow up at all, they charge a further fee for just a simple chat, which doesn't really get anywhere. That post-treatment care, in my view, is really important and actually is a badge of a good clinic. Now, let me just come to some results. This is the biggest study I can find. It's a study which was only published a year ago or 2 years ago. And it's basically 76 different countries, 2,746 IVF clinics, doing a total of 1.9 million cycles. And in that time, they got 439 live births, which is a pregnancy rate of 23%. Now, you can bet your bottom dollar that these clinics reporting, which was a global study, would be the better clinics. The actual success rate with live births per fresh aspiration was just under 20%. you need to know that, because I think actually patients don't recognize that. They're not told that by the clinics. No matter what they actually tell, their figures are always somewhat selective. And so when we consider this particular study by Chambers, which is an important study, it is now a bit out of date because it represents what happened to IVF at that time, say 6 years ago. But nonetheless, it still represents a very similar currently true pregnancy rate. It's probably about 22% in Britain at the moment per IVF cycle, less in older women, more in younger women. And even so, the selection bias in this study is likely to be in favor of making the results look even better than they do here. And certainly, most of these patients have more than one embryo transferred, which of course is something which is not allowed now in Britain, to try and control the number of live births. Because of course, there were 439 live babies, but not 439,000 live pregnancies. Some of those, of course, were twins or triplets. So I think that's important to understand as well. Just to move on very quickly. So here is my suggestion: where you are talking to IVF clinics, you want to have a good standard of investigation, comprehensive treatment for the patient. In my view, the academic units tend to be better because at least they're publishing some research, they're taking it more seriously. Those that communicate with the GP are really important. Sympathetic communication with the patient is really critical. And the question about treatments being modestly charged and proper follow-up being available is important. So, ladies and gentlemen, thank you very much for listening to me. I'm sorry that I kept you waiting so long. I hope I've managed to pack as much as I could into 40 minutes of talking to you. I've now got a sore throat because I've been talking so fast, but there we are. I don't know whether I can answer any questions. Probably not. One thing I might say is that having some really unbiased things, this is not an advertisement. Some years ago, I published this book, which is, I think, costs about £2 on Amazon now. I don't make a profit out of it. In fact, it goes to a research process. But basically, it's a very simple book called The Essential Fertility Guide. There are books like this, but I think this one is really unbiased, and it just simply helps patients, I think, through the whole problem. And sometimes they don't find enough reading material. And whilst I'm not wanting to push my own literature, I do think that perhaps some patients might benefit from something of this kind. Many patients have written to me saying how much they felt that it was a helpful study, written in standard English and without great. It probably needs updating now, but the treatment hasn't changed very much.
Thank you so much. We can certainly get that link and share that later. We do have a few questions. If you don't, would you like me to
yes,
put them in the chat? Shall I move
brilliant,
to you?
sure.
Well, first of all, we have Toby. So Toby Edwards asks, please clarify, does egg freezing have a 2% chance of leading to a live birth or 0.2%?
Oh, let's make it very clear. A single egg frozen, actually, according to the figures, what I did was I could probably append these. I didn't make a slide up because I wasn't sure that egg freezing was really important for this study. Embryo freezing is quite helpful, by the way. In fact, embryo frozen cycles are doing rather better than unfrozen at the moment in general, certainly nationally in this country. Egg freezing, there have been something like, there are about, according to the figures I managed to get out of the Department of Health through asking a parliamentary question, there are several 100,000 eggs in the deep freeze. And taking the results since the last 5 years, there have been something like 40,000 attempts to produce a live birth from numerous eggs. And the overall success rate per egg represents about 0.2%. 0.2% of the eggs actually fertilize, then develop. The figures are misleadingly presented by the HFEA's website because they regard any egg freezing as being the treatment. But of course, egg freezing is the start of treatment. You still have to go through thawing, fertilization, embryo development. So by the time you get an embryo which is capable of being transferred, you end up with only a fraction of the eggs which are suitable. So a woman freezing 10 eggs may have something like 10 times the chance of 0.2%, but it isn't quite, because most of those eggs will not thaw properly. So actually, overall, it's a very, very disappointing treatment. And I think it's probably only justified, where you've got women who've got serious health problems, cancers, for example, which are being treated at a young age, radiotherapy to the pelvis particularly, or chemotherapy, absolutely justified there to do everything you can to stimulate the ovary and try to produce eggs. But the chances are, I think it's going to be, it'll clearly, I don't have yet the figures from the Department of Health about the differences in age. Didn't get that part of my question answered properly, and I need to repeat the question. But I suspect that if you've got over the age of 35, you're already too late to freeze your eggs anyway, and it may even be younger than that. But after that stage, most egg freezing is probably being done too old anyway. It'll have to be seen whether the figures that the HFEA have given me, or rather the Department of Health have given me, really represent the true story, because I think different practice in different countries may be different. The Americans claim very big success rates, but on the other hand, of course, they are extremely selective in what they report. And I think it is such a big traffic. I met a patient the other day who phoned me. She was in tears. She said, I went to a clinic today. I know that you're interested in this. And she said, I went in, I'm 39, I'm under pressure to get pregnant. I went in there, I had a blood test and a scan, and the woman came out and she said, should I use the language she actually used? She looked at the patient with this piece of paper and said, look at these results, they're shit. That's how she started. And she said, what we need to do immediately is to get you in this menstrual cycle, stimulate you. It'll cost you £20,000, and we'll freeze your eggs, and your chances of getting pregnant are 65%. That's a big clinic in London, a very well-known clinic.
Yeah.
So, one has to understand that now. I don't think this woman is telling the untruth. She's somebody who I know, a very, very straightforward lady. But she was devastated, absolutely devastated. And I don't know what she did afterwards, because she's not told me. But I told her I thought that she ought to really be very careful about that sort of information. But it's happening a lot at the moment. So your question's a very relevant one, and a very important one. And I think the HFEA needs to take this much more seriously, because it should be controlled. I will be bringing it back, I think, because I'm about to produce a short discussion paper for one of the journals to look at this issue.
Thank you. That's a really, really interesting reply. Another question here from Lucy asking about, do you have any advice for male partners to improve sperm quality?
It's a very important question. I deliberately avoided talking about sperm quality because, in fact, I think the best I could advice give is that there are some really good male specialists, particularly in the London area, and certainly in one or two other major cities. There aren't enough urologists who are interested in male fertility, but those that are, I think, are really worth trying to persuade males to go to. Currently, what of course is mostly happening is that patients who have poor sperm counts, if they've got any sperm at all which are motile, are going for ICSI, which is IVF with injection of the sperm directly into the nucleus of the egg. That works pretty well in the right patients, but of course, if you've got very abnormal sperm, it doesn't work very well, and if you don't have a very good IVF setup, it doesn't work very well either. So I think the recourse to intracytoplasmic sperm injection, microinjection, which is what it's called, is probably being done far too often. So your question is relevant. What should patients be given? I think, first of all, a proper hormone workup by a male specialist, I think, is really important. Somebody who actually really understands this. And there are, as I say, a few clinics, certainly in West London, there are a couple that I think are doing really useful work. And secondly, looking actually at the actual sperm function tests. There are various things that can be done too, looking at DNA fragmentation, looking at sperm motility in a more dynamic way than is done in a general sperm lab and so on. And I think those things are probably going to be more important and sperm tests. What is very clear, of course, is that smoking, overweight, excessive exercise are all decreasing fertility in a large number of people. It's a number of sportsmen that have been treated in my clinic. Those are going often doing the most aggressive sports like cycling and rugby playing. Some quite well-known rugby stars, have had problems with sperm fertility, and sometimes just persuading them to give up the sport for a while, take a rest, has been all that they needed to do. But it takes 3 months to make a sperm. Spermatogenesis is quite a slow process, so it doesn't happen immediately. And on the whole, unless there's a clear hormone deficiency, or let's say excess, for example, of pituitary hormones, probably most hormone treatments aren't particularly valuable. And wearing white fronts and taking cold baths, I think, is probably mythological.
Some very practical advice there, thank you. And maybe just one more question, and then we'll probably ought to wrap it up. But this one's on the subject of karyotyping, chromosomal analysis. Think of after a miscarriage, very sensitive, very difficult time for the patient, can often occur in A&E or at home. But I was very interested about this idea, which I've not really come across before, is actually doing an analysis, a chromosomal analysis of the product of conception. Should we be doing more of that? How do we do that?
Yes, I think we probably should. I think it's very difficult because, of course, nobody takes miscarriage seriously. Everybody says we will just try and get pregnant again. But I think if somebody's had, more than one miscarriage, it's probably an important thing to do. Certainly, if you've had 3, there's no doubt, and certainly on the 3rd miscarriage, you really should be looking at the products. Karyotyping of the 2 partners, male and female, is generally unhelpful. I mean, of course, you do have translocations sometimes, which are inherited and passed on to the embryo, but they're not very common. And in terms of miscarriage, the problem, of course, is that miscarriage is extremely common. And so, for some women, it's the only time they've been in a hospital would be to have a scrape. But I think, if they are going to go in for evacuation of the uterus, it's very important that they do recognize that the chromosomal test should be available. I think it's a bit hard on the health service at the moment to do karyotyping on the first miscarriage, unless there's a clear reason to think there might be a problem with the karyotype or some kind of aneuploidy. But I think it's not yet enough in mind that really it is quite a common cause of this sort of reproductive failure, and can occur at any stage in pregnancy. Sometimes some late miscarriages may be associated with aneuploidy, although probably most early miscarriages are more associated. But that time you can't usually get the products because either there isn't sufficient material to get, or it's too long after the miscarriage, or in fact the material you do get, the reproductive products, are so deteriorated after 24 hours without a blood supply that you won't get any useful tissue. So it's not an easy ask, and I think it depends to some extent on the individual patient.
Thank you. That's really helpful. Well, I think we'll bring it to a close then. We've got lots and lots of people in the chat saying thank you very much. Really appreciate your time for a really excellent talk. It's been a great sort of whirlwind tour of IVF. So yes, thank you on behalf of everybody here for your time, and really glad we could manage to get the slide sharing, because the images were really interesting.
Yeah, I don't know what's wrong with my computer, but anyway, I've got the second one going. So.
Don't worry, we got there.
All right. You were lucky. Okay, good. Okay, well, all the very best to you. I know it's a hard time for general practice at the moment, and I feel for you. I know how many general practitioners are feeling greatly stressed by practice, but I have to say too that there's some wonderful practitioners. I've been very lucky with my own GP, and I think it's a joy to have a good general practitioner. Because it is so reassuring, even if you're a professional like myself, you still need that kind of reassurance from time to time. And I think that we should all recognize the value. Let's try and persuade the government of the value too. All the best to you.
Thank you, really kind of you. Thank you. Goodbye.